the first renal grand rounds of the year for the months of summer, since July is the academic year starting. We have the first 2 months, the orientation lectures, and it is towards the end of August, early September that we start our regular meetings. Thank you everyone for being here today for our first grand round of the year. As you see, the title of my talk would be the therapy of cardiorenal syndrome in 2025. Obviously, it's difficult to cover everything related to management of cardiorenal syndrome in just 45-50 minutes. So I just use this platform to give you a quick update on the studies that have been published in the last 2 years or 3 years. Since there are a lot of slides, actually the last 2 weeks I have just spent to shorten the talk. Since I have a lot of slides, I suggest that we leave the questions, if there are any, for the end. Unless you see something that you need to be addressed live, in that case, I'll be happy to answer that. So these are my disclosures. None of them is directly related to the talk that I am providing today. You remember that heart failure in general comes in cycles. So the patients are doing fine, hopefully for a long time. Then they have an episode of acute decompensation. They come to the hospital whether with acute decompensated heart failure or renal dysfunction is added to it, and we call it cardiorenal syndrome. Then we decongest them during the admission, because more than 90% of the admissions of patients with heart failure is related to congestion. Actually, to be precise, it is 93%. We decongest them, and hopefully they find themselves well enough to go back home. And a small subset of them had adverse outcomes. So this is the general picture of heart failure. We have, when we look at management, we have 2 opportunities for intervention. One is to avoid admission, and then when they are admitted, to avoid the bad outcome. So this would be the medical therapy, what we call it. And then it would be enhancing decongestion once they are in the hospital, to have the best decongestive strategy for an individual patient. So that would be our goal of management of heart failure / cardiorenal syndrome. Now, in terms of timing, as you saw, decongestion takes place in the hospital, and medical therapy is for stable heart failure patients when they are leaving the hospital. So that would be pretty much what you are expecting. The idea, however, is to start decongestion even before the patient comes to the hospital, and also for medical therapy, not to leave it for after stabilization, but starting it during the admission. That would be the idea of the management of heart failure and cardiorenal syndrome. So if I want to put the outline of my talk for you, I would say in the first phase that we have avoid congestion, then we have reducing the congestion while if they're in the hospital, starting medical therapy in the hospital, and then up titrating it after the patient is discharged. So what am I going to talk about? I will talk about subcutaneous furosemide ambulatory diuretic regimens a little bit, decongestive strategies we touch on, and then we'll have sodium removal. You have heard these from me several times. These are new data that have been added over the last couple of years. We talk about quadruple therapy and how we optimize it when the patient is outside. In the pre-admission phase, subcutaneous furosemide, I wanted to make sure that we all know about this, as it is fairly new. So we have subcutaneous furosemide on the market now since 2022. Actually, it was approved by FDA. It is 80 milligrams. It's a drug device combination. As you see, this is the size of it. It's a palm of a hand probably. And it goes on the belly, and it can deliver subcutaneously furosemide to us. And it is 80 milligrams of furosemide over 5 hours. It gives us a bolus of about 30 milligrams over the first 1 hour, and then 12.5 milligrams per hour over the next 4 hours. So what's the science behind it, or what's the effect that you are going to see with it? I picked two papers that have been addressing. Several studies have been done on this. I picked two of them that I thought more relevant to our talk. One of them is the at-home heart failure trial. So it is a small study. All the studies actually are small with 406. This is 51 patients. This is a phase 2 randomized control trial. They were randomized. The patients are the kind of patients that they are outside and they call you and say, hey, I have gained weight. Hey, I am not feeling well. I have shortness of breath. I have to add pillows to my bed. So the patient is gaining fluid, but it's not in the hospital. So you randomize these patients either to get subcutaneous furosemide or the usual care, which is increasing the dose of. Instead of me telling them, oh, you're on furosemide 20 milligram, add one to your 4 p.m. Medicines. That would be the usual care. The 406 group was asked to use this device, and on average, actually, they used it 4 times during the trial. They followed these patients for 30 days. The majority of them obviously were used within the first few days. What they looked at, they wanted to compare if you do furosemide subcutaneously versus the usual care, does it have any effect? Okay, what did they look at as an endpoint? They went for a win ratio. Just win ratio, for those who don't know, when you have several outcomes, then they have some kind of a hierarchy. One is much more important than the other ones, and you want to get the composite, you use this. So we have cardiovascular death, heart failure hospitalization, urgent visit for worsening heart failure, and BNP. These are the 4 outcomes. You put it together, the endpoints, and then you have the composite outcome. And win, the name goes with it, win or loss for each of the two groups. When they looked at the change in body weight, the purple is the subcutaneous furosemide compared to orange, which is the usual care. There seemed to be a tendency for better weight control with the 406, more weight loss, but it was not statistically significant. When they looked at the dyspnea score, the 7-point dyspnea score, it seemed like that at least at the beginning, the furosemide did much better than the usual care. And when they looked at the whole outcomes, it didn't seem that it reached any kind of significance. So what they decided to mention was that it improved dyspnea, but the composite primary endpoint was not statistically significant. So it's good, but it is not as good as they were hoping for. A second trial that was larger, and that trial was at-home trial was last year. This one was a few months ago. It was published. This is an open-label pilot randomized control trial. These patients have been in the hospital for acute heart failure, now have been discharged. So instead of being pre-admission, this is post-discharge period, right? So these patients are given either the furosemide or subcutaneous furosemide or the usual care. The difference is that they again stratified the randomization by diuretic resistance in the admission that was right before them. Remember, these patients were given this intervention within the 14 days after the admission, after actually the discharge from the hospitalization. That hospitalization, and I will tell you in a few minutes what it means based on diuretic resistance, what did they measure. But for now, we know that if the patient had been prone to diuretic resistance, they have been twice in this arm of furosemide. And if they were not, there was one. There was a 2-to-1 enrollment for with or without diuretic resistance. Okay. Here is what they found. If you look at the diuretic efficiency, which would be, you would say, urine output per milligram of furosemide, those who had diuretic resistance, it seemed that they did really well, meaning that furosemide was helping. But those without diuretic resistance, they didn't see any difference. Same is for urine sodium concentration, millimole per liter. Those who had diuretic resistance, you could see some improvement with furosemide, but in the other group, you couldn't see it. And if you go a little bit more in detail, because the 4-hour peak concentration of sodium was the point of focus for them, and they're looking at hour 2, 4, 6, and 8, there was not much difference when the patients didn't have diuretic resistance. But if they did, then at hour 4, they definitely had better urine sodium concentration. Now, I have to say, when I was looking at these diagrams, they had done the phase 2 studies. They knew that hour 4 is the hour to look for. So it turned out to be really good. But if you look at other hours, there was not much difference. Anyways, what it tells you in general is that subcutaneous furosemide is available. If the patient has a tendency for diuretic resistance, it is more likely to work for the patient, and dyspnea is definitely helped, but whether it helps other aspects like cardiovascular mortality, hospitalization, and all those, this remains to be proven. The second part that I wanted to talk about pre-admission is the treatment that we use before the patients are admitted, or let's say we try to have the best efficiency of decongestion, so the probability of admission will come down. What is a good diuretic regimen? What should I use to make sure that the patient is getting the best benefit of? This is the question. I can't believe that in 2025, we're still talking about this. So this is a randomized controlled trial. It was published last year. Crossover design, refractory volume overloaded outpatients. So they had 3 different regimens. One was just IV furosemide, 250 milligrams. These are all IV, so you realize that they had to come to some kind of an ambulatory daycare unit to receive these therapies, and it is done over 4 hours. So they are going to start like somehow like our dialysis was every day. Anyways, 3 diuretic regimens in 6 sequences, they said. They either got first furosemide 250 or 250 of furosemide plus acetazolamide. You know, after Advor, everybody is using acetazolamide, 500 milligrams per day. And you realize that US has intravenous acetazolamide. Many countries, first world countries, they don't have it yet. And then we have IV furosemide 250 plus metolazone 5 milligrams per day. So there are 3 different regimens. Each patient is getting all of them, but in different sequences. So if you think about it, sequence 1, for example, is a patient who gets first 1 week furosemide, another week furosemide and metolazone, another week furosemide and acetazolamide. But sequence B would be furosemide and metolazone, and so forth. These are different sequences. A small study, DA heart failure study, 42 patients. Mostly it is a proof of concept. What do they find? They look at urine sodium, they look at urine volume, and they look at weight difference. And not surprising to many of us, furosemide plus metolazone seems to be doing better in the 3 markers. So it gives you better urine sodium, better urine volume, and weight difference. This was what I would say, the conclusion of the study was. But I want also to mention something else to you that caught my attention. And this is something to remember, that when we say something and we back our argument with a study, there are always other studies that might not show that. So in Advor, you remember that the main finding was that they had furosemide versus furosemide plus acetazolamide, and this one gave a lot more urine sodium. That's why they went for it, and they thought, and now in the European Society of Cardiology, one of the first interventions that you do when furosemide alone is not sufficient. But in this study, actually, if you look at it, whether you use furosemide alone or furosemide plus acetazolamide, your urine sodium is not meaningfully different. So that's just something interesting on the side. When they looked at the safety. The efficacy was there, but what about the safety? When they looked at the safety, they found that furosemide plus metolazone will give more worsening renal function. For the audience at the University of Florida, we have talked about it so many times for many, many years that I doubt you will have any problem. For those who might be new, I should say that when you are decongesting a patient with heart failure, increase in serum creatinine is not necessarily bad and may actually be a good sign, but something to consider. So this should not deter you from thinking about the result of the study. If anything, it might be a positive sign, in my opinion. So we talked about pre-admission, we talked about subcutaneous furosemide, and we talked about the regimen that we use. Both of them are with the hopes to keep the patients outside of the hospital. But what if the patient is admitted to the hospital? One of the main things that over the years I have been talking about is the residual congestion. So a patient comes with acute heart failure, we give them the therapy, which the majority of the time it is IV diuretics high dose, but not everybody gets decongested the way we like it, right? So many of you actually, have seen this so many times. Probably you are tired of this slide. This slide shows the change in weight versus the percent of the patient. So the patient comes with fluid overload and increased weight. We give them IV diuretic and we follow their weight. The hope is that they lose weight, right? They lose weight, meaning that they are decongested. What it showed was that 33% of the patients lose less than 5 pounds, between 0 and 5 pounds, and it is not kilograms, pounds. And even 16% of the patients gain weight while we are trying to decongest them. So we said that around half of the patients either do not lose much weight or even gain weight and then leave the hospital when they have come for acute heart failure and volume overload. But if you think about it, this is from 2005. We have so many other therapies these days in the outpatient, the chronic. Has it changed? Now we have SGLT2 inhibitors. Now we have neprilysin inhibitor. Is it changing? That's the question. So I showed you that to tell you that I have been on the look to see if there is any new data coming out. And sure enough, it came out just a couple months ago. This is the post-hoc analysis of relapsed acute heart failure. Remember that relapsed acute heart failure, they were using serelaxin, a hormone from the pregnancy that is supposed to help the hemodynamics in acute heart failure. But that study, which actually was published in New England Journal of Medicine, turned out to be negative, meaning that serelaxin cannot be used for treatment of acute heart failure. So they have used the data from there, and they looked at the different days that the patients had their congestion assessed, and they looked at day 5 based on 3 things. We have something we call composite congestion score or clinical congestion score. It can go from there are different scoring methods. This one is from 1 to 8, and there are 3 elements in it: orthopnea, edema, and JVD. Okay. So they looked at it. Let's see what they found. This is what they found. They found that the great majority of the patients have some sign of congestion. This is any sign of congestion on admission. Then they get decongested, and it seems that it is actually going well. They continue to be decongested, and this is day 5, and this is at 2 weeks. Well, 2 things come to my mind when I look at this diagram. Number 1 thing that drew my attention is this one. It seems that between day 5 and day 14, there is not much difference in congestion. The percent of the patients with some degree of congestion, it doesn't seem that we have a major change. And remember, these patients during this period are not necessarily in the hospital. I should say that they had around 6.9 day average length of hospitalization. So the great majority of them have been out here. But what it tells you that when they came to the clinic, there was no difference between day 5 and day 14. And probably more importantly, actually, is this for me. It tells me that at 2 weeks, nearly half of the patients still have some sign of congestion. So there is residual congestion when it comes to heart failure. As good as we think we are, the congestion is incomplete. You might argue that it might not be needed, that we can talk about that. But whatever it is, the current state is that we are not completely decongested at day 40. What they found and they reported was this actually. They said, look, day 5, more than half of the patients still have some sign of congestion. And not only that, nearly 20% of the patients have significant residual congestion at day 5. This is the concept, if you remember, and that I had discussed with you when I was talking about ultrafiltration. And this is for the fellows mainly. You know, guys, the patient comes to the hospital, you start them on high dose diuretic, and if by day 5, 6, you don't see a major difference, then at that time, nothing helps. You can't say, I use ultrafiltration, and now I compare the outcomes to diuretics. At that level, probably nothing is going to help that patient, unfortunately, which includes ultrafiltration. That's why all the efforts are just focused to the initial part of the admission. And you remember that a patient with heart failure has an average length of stay of 5 to 7 days. Okay. And this is on 5,900 patients. So does it have any impact on let me rephrase, not impact. Does it have any correlation or association with the outcomes? Yes. If on day 5, I have not been decongested very well, the cumulative incidence of adverse outcomes written here, this is renal failure, would be worse compared to somebody who had better decongestion on day 5. So you see the difference. And this is an interesting concept. This can be on its own a different renal grand round. What we say is that congestion has a very tight association. Several studies have shown it with the outcomes. But decongestion, there are conflicting results that if it improves the outcome or not. If you think about the chlorotic, the one that used thiazide plus furosemide, it helps the congestion. The outcome was no different. Advor, the same. Decongestion was there. The change in outcome was not there. So congestion has a very tight correlation with the outcome, but decongestion, we don't know. There are conflicting data. So what have I said so far? I have said that decongestion is the goal in hospitalized patients with heart failure. We just saw that lingering congestion is common in these patients. And the question you and I may have now is, can we predict this? When the patient hits the door, can I say, hey, patient A will not have good response to my therapy compared to patient B? And you know, there have been several formulae and several ways of doing this to say what we call diuretic resistance. We are changing it to diuretic efficiency these days, right? So there are different ways of doing it. But if you think about it, the majority of them, you do an intervention, then you see the result and you decide, right? For example, furosemide stress test. You give them a dose of furosemide, then you look at the urine output and you decide. Or in the algorithm for the diuretic therapy, you give them twice the dose of the home treatment IV diuretic. Then 2 hours later, you look at the urine output. If it is less than 50, you decide the patient needs reinforcement, right? So they have some kind of information. The question now I have is, is there a way for me? Can I predict the response to diuretics when the patient just has arrived to the hospital? There is a way now. We call it BAN ADHF score, and it was published last year. So this is one of those machine learning new things that we have and we use to help us for prediction of events. So they used three trials of acute heart failure: ROSE, AHF, CARES, and ATHENA. You remember that ROSE was looking at dopamine and necirotide, CARES is ultrafiltration, and ATHENA is MRA. So they looked at around 800 patients. That's their derivation cohort for the scoring system. Then they need to validate it. So the validation cohort would be two trials: dose, which is two different dose and routes of administration of furosemide, plus ESCAPE. ESCAPE is the one that is pulmonary artery catheter, and it was a negative study. So two trials were the validation, and they looked at a number of different parameters that you see here, 8 different parameters. In this one, and the majority of them, creatinine is absent. You know that creatinine doesn't have a good predictability in heart failure. But here, creatinine is here. Also, BUN is here, and diastolic blood pressure is here. The lower your blood pressure, the higher the likelihood of diuretic resistance. So these are the 8 ones, and it goes from 0 to 26. In terms of diuretic efficiency, they had 3 phenogroups. That obviously the one that has lower diuretic efficiency here was the same for the validation. Okay, so they could predict which patients will have less diuretic efficiency. It was pretty much the same for the validation group. When they looked at the length of stay, they found that the same group that had less diuretic efficiency obviously is more likely to stay in the hospital longer. It is interesting to know, but it is not surprising. If I'm not responding to your treatment, I'll stay in the hospital longer. What about global well-being? Sure enough, the patients who had lower diuretic efficiency had lower global well-being as well. The 3 groups are pretty much the same concept, both in the derivation and validation cohorts. So when you look at the overall area of the care and you say, wow, this is really good. BAN ADHF had a 0.92 area of the care. And for those, probably for the fellows, you might want to be as close to this upper left corner. The closer you are to this point, the better your predictability is. For example, if you look at this one, MAGIC, for example, it's almost flip of a coin. 50-50 can be true or not true. But this one has a good predictability. Both the specificity and sensitivity are reasonably well. MAGIC, by the way, is the risk score for heart failure, and it has age, GFR, blood pressure, and BMI in it. They use it for the mortality and risk score, but it doesn't seem that for prediction of diuretic efficiency, it has a lot of help for us. So does it help with in-hospital mortality? This is what we are going to see. It has diuretic efficiency there. This is per 5 unit of increase in the BAN ADHF, and you see that if it is more than 12, your score, this is high. Lower score is better, obviously. So, and you see that in hospital mortality goes up with increase in BAN ADHF. So it seems that to be a new guy on the block for us for prediction of response to diuretics. So let's say we predicted and we know that the patient might not have a good response to our therapy. Then what? First of all, let's see what we should be expecting. You may have seen this slide. I have used it in my previous presentations. I don't know if it was in renal transplantation or elsewhere. So these are patients with acute heart failure. They came to the hospital and they were put on a 2 gram per day sodium, and they checked their sodium balance in terms of what they have in the urine versus what their intake is. What they saw is not really unexpected for us. It says if you have a positive sodium balance, your survival is not as good as somebody who has a negative sodium balance, right? Interesting, but not unexpected. What is probably unexpected, or at least interesting, is this part. It tells you, compared to somebody who has negative sodium balance. If you have a positive sodium balance, you are in a bad shape, even if you have lost fluid. Again, reminding us that what is important is not the amount of urine that you are generating, the quality of it. And what do I mean by quality? But the amount of sodium in the urine, natriuresis. What it tells us again is that urine sodium counts. Several studies, obviously, have been looking to see if they can guide the therapy of heart failure based on urine sodium, based on one of the studies you saw, and there are a number of studies there. So what you know it, the patient comes, we give them a dose of diuretic, and then 2 hours later, 6 hours later, 12 hours later, we look at the urine sodium, and it guides us what is the next step. Should I continue the same dose? Should I increase the dose? Should I add a second diuretic? So these are different studies that have been done on these. Two of them I'm showing you. Push acute heart failure was done a couple of years ago, was published in Nature Medicine. What it showed us is that if we guide our therapy by urine sodium, we definitely will have much more sodium in the urine compared to conventional method. Is it surprising to you? Not to me. If I am guiding you by urine sodium, obviously you will have more urine sodium in the urine compared to the other one that didn't even look at urine sodium and decide what to do. What is important for me if it has an effect on the outcomes. Unfortunately, it doesn't. At 6 months, they have the same outcome. So yes, we improve natriuresis. As I told you, decongestion, that's the problem with decongestion, but we cannot see a lot of impact later. One of the reasons I have to say is that what you do is during the admission, the patient leaves and it is on normal or usual care. So there are so many competing factors after the discharge that might change your outcome. That's probably why you don't get what you are looking for. The other study is ENACT heart failure, same way. Primary endpoint was natriuresis after 1 day and compared to the standard of care. If our treatment was guided by urine sodium, we did so well in terms of taking out sodium. The same is for cumulative natriuresis and also even the diuresis. So in general, these approaches that are guided by natriuresis will give us better urinary sodium excretion, but whether they will change the outcome or not, I'm not sure. They may, but again, there are a lot of competing factors after the discharge. So how do I counter diuretic resistance? Or maybe now these days I should change this and say strategies to improve diuretic efficiency. We are changing diuretic resistance to diuretic efficiency, okay? Because diuretic efficiency is something objective. Diuretic resistance has been pretty much a subjective matter. Milliliter of urine or millimole of sodium per milligram of furosemide is diuretic efficiency. Okay, we have tried nesiritide to see if it improves natriuresis, didn't work. Dopamine, it didn't work. Hypertonic saline and ultrafiltration, they might have some effect. This is again, there are conflicting results, and probably we need more data to be more specific about them. But sequential nephron blockade has been there for some time, and it was actually the topic of my grand round. If I'm not wrong, 3-4 years ago, we went through one by one all the studies, and we showed that there is a lot of evidence. This is the summary of it, actually. It shows you that on top of loop diuretics that are the mainstay of treatment of acute decompensated heart failure, any of these, SGLT2 inhibitors, thiazides, MRA, calcium carbonic anhydrase inhibitors, and V2RAs, Vaptans, can be used to improve the diuresis/natriuresis. And I don't know if you remember from those years or not, thiazides again seem to provide more natriuresis compared to all other ones. There is a lot of hope for SGLT2 inhibitors, but they improve urine volume quite a bit. In terms of the urine sodium, it's not much. Whether it is because it is diluted in this big urine volume, that's a matter of discussion. Okay, so I talked about pre-admission. Now we talked admission, and we are getting ready to discharge the patient. Okay, we're still in the hospital. The question would be the guideline-directed medical therapy, the quadruple therapy for heart failure, which would be beta blocker, RAS, or nephrolysis inhibitors, MRA, and SGLT2 inhibitor. This is the quadruple therapy. For the fellows, again, remember, please, diuretics are not part of medical therapy for acute heart failure. You use them for symptoms, but they do not have an impact on the outcomes, so they are not considered part of the quadruple therapy. These four improve the outcomes. Okay. So the question would be, these quadruple therapies, when do we start them? Should we wait when the patient is stable outside of the hospital, or during the admission for acute heart failure, you should start it? Just the way I am asking you the question, you know the answer. Yes, we need to start them during the admission. Why? Look at this study. This study is 12 months after a patient has been in the hospital for acute heart failure. Looks at them to see how many of them, or what is the percent of them having beta blockers or RAS or MRA. It tells you if the patient was started on beta blocker during the admission, this is the percent of them at 12 months still on beta blockers. But if you didn't start them on beta blocker, this is what you are going to get. And this is good. This is for beta blockers. Look at the MRA. Unless you start it in the hospital, it is less likely that somebody starts it afterwards. You know, there are always reasons for us that, oh, the potassium is a little bit on the high side, or the blood pressure is a little bit soft. There's always something to say that, let's wait, right? This tells us that if we want them to be on this therapy, we know that GDMT works quite well, helps improve the outcomes, then the time to start it is when the patient is in the hospital for acute heart failure. You will say the patient is unstable, he's in the hospital, but that's what it is actually, right? And you will say maybe day one. No, they're not day one. Maybe it's close to discharge. You will see that it's not even the case. So if you look at the guideline-directed medical therapy and you want to know, when do I start it? You tell me, start this during the admission. But when during the admission? The admission is 8 days, 7 days, sometimes even more. When? Well, this one said a little bit after the admission. I don't know. They didn't put some number on it, but it told you that, hey, start it. And why did I put this red? Because these have cardiorenal benefits. This one seems to be more of a cardiac benefit. So this says start RNA and beta blocker first, followed by MRA, followed by SGLT2 inhibitors, right? This is what you know that we need to start it. But not everybody agrees with this. For example, this is European Society of Cardiology guideline, and they tell you actually, look at the EGFR and decide. If your EGFR is good, start the patient ASAP. Just start them right away on 4 different medicines: beta blockers, SGLT2 inhibitors, RNA, and MRA. If the GFR is a little bit lower, 30 to 60, think about not starting MRA, but the other 3. What about less than 30? You know that less than 30, we try not to use nephrolysis inhibitors. Although I say not to use, I have patients ESRD on nephrolysis inhibitor. But less than 30, typically you change to ACE inhibitor. So beta blocker, SGLT2 inhibitor, and ACE inhibitor. And then when you go to lower than that, they say low dose ACE inhibitor, and then other stuff. Just be more careful. Less than 15, obviously, you're a little bit more cautious. The point I want to make with all of this, we are not going to remember all of this. The point I want to make is that for a GFR of more than 60, You start the four of them probably ASAP. It doesn't tell you what day, but I have another study that, not study, another paper that tells you when, but at least for this one, it tells you start when you are comfortable. This paper came out 2 weeks ago, and this is an editorial on a paper which is on strong heart failure. Strong heart failure is the timing of initiation of um, guideline directed medical therapy, GDMT. So that one showed that for the average of GFR, whether you are above or below the median GFR of that group, it did not affect the outcomes or the safety if you started the four of them either simultaneous or very quick. Here, this is what they say. Start them on day one. So think about it. Mr. Brown is admitted for acute decompensated heart failure with volume overload. You're starting him on 80 milligram BID of IV furosemide, and you are starting him on ARNI, beta blocker, MRA, SGLT2 inhibitors. It's given that many of them have these medicines. We need to continue it at least. Based on this, at least don't stop it. But again, this is based on the fact that within the first few weeks you see the benefits. So 1 or 2 days counts for them to start them as early as you can. But again, it is soft. It depends on how you feel about it. And for our patient population, which is a group with GFR typically on the lower side, probably if you want to be conservative, what the European Society of Cardiology had suggested, you might feel more comfortable. But it depends on the style. The point you want to take home is that I need to start it in the hospital and as soon as I am comfortable, maybe day one. So the patient was in the hospital. We went through pre-admission, now through the admission, before the discharge, and now the patient is discharged. The first question that you have, should I use furosemide or torsemide? I put this here because this is a topic of discussion all the time, but there is a new study that came out just last year. I want to mention that. So in outpatient chronic heart failure, we know that furosemide is by far the most commonly used loop diuretics compared to other two, right? The number doesn't matter. Here it says more than 80% of them are furosemide, around 10% torsemide, or a little bit less Bumex. So this is by far the most commonly used. The question would be, is there any difference between furosemide and torsemide? And we have talked about pharmacokinetics, pharmacodynamics. We have talked about it so much. Once forever, this randomized control trial published in JAMA 2 years ago told us it doesn't matter. Just whatever you are comfortable with, knowing that torsemide is more expensive than furosemide. Whatever you like, just use it. It's not a big deal, and there was no difference. This is Transform Heart Failure trial. And even for you and me, is it the same for all GFRs? Yes. They looked at subgroup analysis, and this is what they found. Your GFR is less than 30, between 30 and 60, more than 60, it's the same. So GFR should not be the driving factor for you and me. Maybe your habit, what you like, and knowing that torsemide is not necessarily associated with better outcomes. But this is the paper that came in our own JSON last year, and it is from Yale Group. They looked at, this is the Transform Mechanism trial. It's a sub-study of Transform Heart Failure trial. What they looked at was the natriuresis, a subgroup of patients, 88 of them, right? They looked at the natriuresis with torsemide versus furosemide. It's a very long story. To give you the final verdict, they are suggesting, again, going back to 4-to-1, equivalence. So you and I, we typically say if you are on 80 milligrams of furosemide, go to 40 milligram of torsemide. If you want to change from furosemide to torsemide, 1 to 2 we go typically, because most of the studies have been done based on the pharmacokinetics. But this is pharmacodynamics, and they showed that in terms of natriuresis, an equivalence factor of 4 to 1 is better. And actually, our own Dr. Belal, one of our former fellows and currently a faculty here, in April went to National Kidney Foundation, presented his abstract to tell us that the great majority of trials that have been, there has been so much inconsistency. Think about it. We take the results without even knowing what was the dose of the diuretic. It might change the whole concept, right? Not only there was much inconsistency, but the majority of them had been using 1 to 2. There were some papers that had used 1 to 4 before all this. The last concept I want to introduce today is that, okay, you told us about the post-discharge that we don't have to worry about furosemide or torsemide, and the equivalence might be towards 4 more than 2. And you know, just to give you an idea, a patient calls you and they say, hey, I have been on 80 milligram of Lasix, and it seems it's not working for me. I am gaining weight. And you say, okay, take 40 milligram of torsemide, and then 2 weeks later, it works so well. But you know what? You might inadvertently increase the dose of diuretic. You went by 2, why you had to go by 4 if you wanted to give the equivalence just to change the medicine. So some of the results that I personally am a fan of torsemide myself, but some of the good results that we have seen in our patients, that study tells us that maybe because of the dose that without knowing it, we had increased the dose. Okay, sorry, I just went back to that study. Let's go back to this. This is our last part of the talk. So for the longest time, you have heard this from me. At the top, I wrote here for you, now old news in acute decompensated heart failure. Basically, what it tells you that if a patient comes with acute decompensated heart failure and is volume overloaded, and you decongest the patient and the creatinine goes up, you shouldn't worry. Why? Because the outcome is the same. If I have no congestion, but the creatinine goes up, compared with somebody who has no congestion and the creatinine has not gone up. Basically, what this trial, and this is one of the first trials, Marcometra from Italy did it, but several studies after this came out, and they told us that it is the congestion that is the driver of outcome, not the worsening renal function. And this is in acute decompensated heart failure. I want to draw your attention to a point. When you say worsening renal function, or I call it increasing serum creatinine, we are talking about these studies are all done 0.3, meaning that my creatinine goes from 1.2 to 1.5. It doesn't have an adverse impact on my outcome. But what about if it goes to 0.5? What about it goes to 2.5? What about if I am on dialysis because of high dose diuretics and my creatinine is getting worse? Then what? So we don't have a threshold, and it has been bugging me forever. There is a paper actually that's coming out that is going to answer this, but it hasn't come out yet. In acute heart failure, what has come out is in chronic patients. This study was published a month or 2 ago in our own CJSN. It's kind of a very long study. In short, this is a post-hoc analysis of Everest trial, 3,400 patients. So they looked at the patients outside of the hospital. The patient have left the hospital after the discharge. They looked at them, their congestion improved, their congestion worsened. And then they looked at the GFR. Some of them, GFR did not change, no decline, 1% to 20%, 20 to 40, more than 40. The same for groups for the congestion worsened. So 8 groups in total based on congestion and change in the GFR. Let's see what they found. Well, it is a very dense slide, but I make it very easy. Hope, at least, hopefully. One is that there are three different outcomes they're looking at. It doesn't matter, all-cause mortality, cardiovascular mortality, or composite, right? They look at two different things. Kidney function exposure, again, no GFR change, GFR decline 1 to 20%, 20 to 40, and all those. So four different. And then looking at the volume, congestion improved, congestion worsened. So two different elements for each of these categories. To make it easier, clean it up. Look at any of these three. Let's say we take the one in the middle. What it tells you is that if you look at renal function and the congestion separately, it's very easy. It is what is expected. The worse my GFR, the worse my outcome. That is not really anything. Between congestion, no congestion, better. With congestion, worse. So separately, there's really nothing big. What if we put them together? That's the point. Here we are. If congestion worsened, regardless of your GFR, you are in a bad shape. The worse GFR, the worse is the outcome. That is what he's telling you. But more importantly, look at those patients whose congestion improved. If their GFR went down a little bit or didn't change, they are in a good shape. If it went beyond 20% decrease, it seems that it is getting a little bit to the shady phase. And if it is more than 40%, it is associated with worse outcomes. So now we have a threshold for the chronic. In chronic heart failure, you are giving diuretic to somebody and you're looking at the GFR. If it goes up to 30, 35, 40, you still can say permissive hypercreatininemia. If it goes beyond that, you might want to consider changing your strategy. So basically, between the two pillars that we said, decongestion and medical therapy for heart failure, we say that in the hospital, after the hospital, sorry. This is the editorial by Steve Kolka. I don't know if it is really a good representative of what he wanted to say or not, but it just basically tells you that if the GFR goes all the way to 30, it's okay. You are still getting benefit from the therapy. Between the 30 and 40, you start to think about it, but beyond 40, you might be hurting the patient. Okay. What's the take-home message? Heart failure therapy has two pillars, decongestion, that we don't think it has necessarily an impact on the outcomes. We don't know. We said there are conflicting results. Medical therapy definitely has cardiorenal benefit. The battle against congestion should start before the patient is admitted. We talked about two different strategies, subcutaneous furosemide and optimization of diuretic therapy. We talked about furosemide plus metolazone being a good option. The third one is that residual congestion is still common in 2025, similar to 2005 that we saw. And then we talked about natriuresis guided therapy and sequential nephron blockade. And then finally, we said that we should start the GDMT before the patient is discharged from the hospital. I think I finished 2 minutes ahead of time. Thank you very much for your attention. Let me remove this and to see if there are any questions. If I can open my Zoom, I'll be happy. Stop share. Okay, perfect. So I wonder if anybody has questions. I know that we are getting close to 1 o'clock. I invite people to leave when if they have other things to do, and those who want to stay, they are more than welcome to stay. Are there any questions?
Can I ask a question, Dr. Shah here?
Dr.
Great presentation. We always look forward to your presentation. It was so educational. I had a comment and a question, and nothing to dissent, just the practical problems with the natriuresis guided therapy with urine sodium. So, since we saw the data, I've been trying to do that in any patient. It is just so hard to get the nurse to do the urine sodium on a regular medical floor. Like sometimes we order the urine sodium and they'll just add it in the previous urine sample collected from morning. Like you just do not get it right away as you would like to get it, unless patients in ICU. So it's just that I love to do urine sodium, but it's just becomes very hard practically. Maybe in the future, as the nurses get more trained, residents get more trained, we'll get the 2 hour fresh sample from the Foley to do the urine sodium. I hope that we can do that more in the future. My question was, it's a little out of your presentation discussed today, but I just want to learn from you that what are your thoughts on CardioMemes machine that they've been using? And just for the audience, I have a few patients. They use the machine. You can educate us more. They use the atrial pressure real time and use the diuretic therapy based on the atrial pressure. Has it shown to improve decrease the hospitalization or outcomes or anything because we are using the machine to do the same now?
Yeah. First of all, with your comment, I wholeheartedly agree with you. And sometimes I see this in the papers, even that they say, you guys in academic centers, you have everything, and you think that this is easy to do in community hospitals. We don't have access to it. I want always some to say that even in quaternary centers like us, it's not always easy to get it. But we are more likely to have that compared to others, and we should know that it is important. But you are quite right about the practical aspects. I 100% agree with you. In terms of CardioMEMS, there have been conflicting results, and this is because there is always a difference between pressure and volume, right? It gives you a good idea of the pressure, but not necessarily the volume. And this, again, is actually even correct with POCUS. If you think about it, that one gives more idea about the volume than pressure. So with CardioMEMS, it is being used more and more. It guides the therapy in the outpatient, but whether it will be universal, at this point, there are conflicting results, as you know. So I'm not sure about it.
Thank you.
Thank you.
I have a question, Dr. Kazory.
Please.
I'm a really great talk, like Dr. Shah said, it was amazing.
Thank you.
It's more like a practical question, like, in treatment of like diuretic resistant acute decompensated heart failure, have you or anyone else used hypertonic saline with the furosemide, and if so, what protocol do you use? Is that same as using like 2% saline, or what is the protocol?
Yes, hypertonic saline, I haven't used it myself. It needs a little bit of just courage to use hypertonic saline in somebody who has been coming for acute decompensated heart failure and volume overload. The first studies came from north of Italy. Dr. Paterno, if you go to the literature, several randomized control studies came from there. But then the results that he had offered had been questioned. It was single center and all those. So Yale recently did a small study, if I remember well, it was around 50 patients or so, and showed better natriuresis, right? Whether it can be helpful or not, I think there is some I would say, some evidence behind it. And interestingly, the evidence that is behind it is not about hypertonic saline being the sodium. What they think is that we are repleting the chloride, because hypochloremia has been shown to induce diuretic resistance. They think that this is the reason why we improve it. Again, there is really limited data. It is not universal. Some studies, I know that one of our former fellows, actually, who is at Georgetown, she told me that she's using the Yale protocol for hypertonic saline in patients with acute heart failure, but I don't think that at this point it is very widespread.
Thank you.
Yeah.
Dr. Kazory, I have a question.
Please.
Thank you for the talk. Really interesting. How do you define decongestion? Like, what parameters you use?
Decongestion, this is yet another thing, Muhammad. A few years ago, and when I say a few years ago, now I am getting old. It's 10 years ago. 2015, American Journal of Medicine, Dr. Testani published a paper and compared the clinical signs of congestion, and it showed no, I would say, correlation between the three of them, right? The JVD and weight and urine output. His point was that, hey, what we are using, we are not necessarily using the right metrics. We need something more objective. To this state, you saw that we don't have a lot of options, again, because of the practicality of these patients. This is the most common reason for admission of the patients after the age of 65, right? So we can't have very, I would say, widespread use of point of care ultrasound to tell us. I personally would think that it would be very helpful, but you cannot. If you saw it in most studies to be consistent with other studies, they were using composite clinical scoring, which would be three things: the JVD, the orthopnea, and the edema of the lower extremities. And they give you different scores, and then they add the scores together to decide if the patient is congested or not.
Thank you.
Did I answer your question?
Thank you.
Perfect. Well, are there any questions? If there are not, thank you so very much for being here today. And for the candidates, best of luck to you. It's been a pleasure to have you with us today. Have a great weekend, everyone.
You too. Thank you, Dr. Kazory.
Bye-bye.
Thank you.